Hi, class. Let's go over the clinical management practice cases and examples that I gave you a few class times ago. So this will be good review for the test. You should be able to follow along and remember this will not do you very much good if you haven't already filled out the answers. So you're going to see that on mine. I basically have a key in which I filled out all the answers. If you have not done that, please do this on your own now before beginning the review, because I'm not going to type and fill in the answers as I go. They're already there. I'm just going to speak as to why they are the correct answer as required. So let's start with this example. At the top says practice cases, and number one is about Michelle. So Michelle was trimming her bushes, woke up with pain in her forearm, so on and so forth. You see the clinical examination findings down there below. You should be able to easily pick three tissue-specific impairments. The first that I listed was anterior forearm edema. Anterior forearm edema. And what gave you that finding? You know, what confirmed that diagnosis? Well, you look at your data under palpation for condition. You see that you have some swelling over the flexors and the anterior forearm. Now, if it was just over the flexors, I would include it just with the other impairment, which was tendinitis. So the other would be, it turned out based on your MSTT and such to be flexor digitorum profundus tendinitis, and then anterior forearm edema. So you're given a specific location of the edema, that is the anterior forearm. So I would list it as such as a separate impairment. The FDP tendinitis, you have the MSTT finding strong and painful, and we told you it was the FDP under MSTT. You have some tenderness when you palpate for tenderness, and under the palpation for condition, you have all this swelling and such. So it should give you those two diagnoses. And then the joint capsule of the MCP. The best step to really back up that finding is going to be passive range of motion accessory, and you notice that in both directions it is hypomobile with a tight joint capsule end feel. And as you recall from the capsular pattern, that really fits the capsular pattern. What you're missing is the active range of motion data and the classical range of motion data, but you still have enough of those findings with accessory that you could make that diagnosis. As you scroll down into number two, all right, these are your tissue-specific impairments on the left, and in red is the best step you should use. So if you have a weak triceps, your go-to step to get tissue reactivity is going to be the MLT, because, of course, that would stress a weak tricep the most as far as passive stress that you as a therapist are putting onto the tissue. So remember to go back to the purpose of each step and to the definitions you've been taught and are learning so that you can work out these things and show some clinical reasoning. As we move on, subacromial bursitis, the best step to get tissue reactivity is going to be palpation for tenderness. That's what PFT stands for. For a tight joint capsule, it's going to be passive range of motion accessory. So the best step for the capsule when we specifically test it is also the best step to determine the reactivity. So passive range of motion accessory is kind of a neat example in that respect. We see that the anterior forearm edema would be best stressed, or would be best able to tell tissue reactivity from palpation for tenderness. Okay, now if you had anterior forearm edema and under passive range of motion classical for something like elbow flexion, you had a swelling end feel, that tells you that you are actually stressing that tissue. And you could always argue that, well, the edema is the tissue we're talking about here, would be most stressed by passive range of motion classical and that overpressure versus palpation for tenderness. So if you had other findings, such as passive range of motion classical, a swelling end feel, and when you did passive range of motion accessory, there was nothing as far as swelling was concerned, then you definitely could use passive range of motion, classical elbow flexion in this case. But your go-to, generally speaking, for that edema is going to be palpation for tenderness. Move on and talk about Barry. So Barry fell 10 weeks ago, so he's got this settled to chronic issue, and we decided to call it settled, and his tissue reactivity is low, and he has moderate subject reactivity. All right. He has multiple impairments. He has a tight joint capsule, and he has a tight triceps muscle. Now, here's something to keep in mind. Don't forget, considering all those variables, your treatment should be realistically, it'll be positive. It'll happen. So if you have a tight joint capsule, you want to assume that you'll be successful. You want to assume that you will be successful with that treatment. So if they have a tight joint capsule and it would be appropriate to actually get a mechanical change that session, then assume that that will happen within reason. We see that we have a tight triceps muscle as well. So think about it. Would you need full glenohumeral joint motion, particularly a couple of motions like elevation, right? So you need full elevation or full shoulder flexion, and you would also need full elbow flexion to actually stretch the triceps. So could you really get there to treat the triceps unless you had already treated the joint capsule? And of course, the correct answer is no. The correct answer is no. You couldn't have done that. So what you have to do with this type of case is you have to treat the capsule first, or else the capsule would prevent you from fully stretching the triceps appropriately. So, do you need a palliative in this case? No, you don't need a palliative treatment. Preparatory to my corrective, I could put some heat on the triceps, and I'm also going to do a thermal ultrasound deep into the capsule, the glenohumeral joint capsule. Under corrective, now this is when I try to make a change. So listed first, I must have that I treated the capsule. So you could do grade 4, and you could say all directions, or you could say you did end range holds in all directions, but you need to name the directions you're doing. You can't just say grade 4 by itself. You'd have to say like grade 4 all directions. You could also say grade 3. That would be acceptable as well, but because tissue reactivity is low, there's no reason why you need to get a lot of pain gating effects. You can go in there and treat the problem. After that, if you had gotten mechanical changes to where you could get a significant improvement of motion, if not normal motion, then you can start to stretch the triceps. So manually stretch the triceps, and then supported for each of those. If you stretch them in the clinic, they have to stretch at home. You would show them how to do self-stretching at home to maintain those gains. And then remember a functional active range of motion to support your mobilization for mechanical effects. We always want to do that. So I just wrote overhead reaches in this case. Let's move on here and talk about Mr. Jones. Mr. Jones, 65-year-old retired accountant, loves to play softball and tennis each week. You're treating him because he's got a supraspinatus tendinitis. So we know that that's wrong. Supraspinatus tendinitis, we know that is his tissue-specific impairment. He is in the subacute stage of condition, and that reactivity is moderate. Okay, so the tissue reactivity is moderate. So what's your functional goal? Well, remember, functional goals should be functional, objective, and measurable. They need to meet those three things. So what I wrote, and there would be several correct ones, is I discussed throwing. Now, he talks about all this. He has pain while he's making his chili. He was trying to help his wife vacuum. So, sweeping and vacuuming causes him pain. So why do you think of all those I chose throwing? Should be a good answer for that. The reason why is if you look up under his goal, if it didn't give you his goal specific to any of those, you could choose any of them. But his goal is to play third base. And so because he wants to play third base, I know I need to make that goal directed towards softball. So that's what I did. So it shows that the patient will be able to assume full cocking phase of throwing 10 times while gripping his softball without pain or compensation. So it's functional because it has to do with throwing and softball. It's objective because I have some numbers there. He'll do it 10 times. He won't have pain, so 0 to 10 pain. And it's something measurable that somebody else could make sure they're doing when they reassess the patient, or you could spot check them when they come back in on your initial reassessment. So that's that sheet, and now let's pause and switch to the other one. Okay, so now we're moving on to the other sheet. Let's start at the actual top of it with number 1. All right, so the examination step in which you're most likely to find the subject reactivity would, of course, be the history. Definitely be the history. That's when the patient's really reporting about their functional ability. Now, we also will use functional outcome measures and discuss those from time to time, but if you don't have specific data on those, the overall examination step is going to be the history. Number 2, which examination step would you use to find the tissue reactivity of glenohumeral joint laxity? We have hit on this several times now. It would be passive range of motion accessory. Based on the definition for tissue reactivity, that is the best match. Number 3, how do you grade the tissue reactivity of somebody with a right greater trochanteric bursitis if they have pain with superficial palpation during palpation for tenderness? Well, then it's high. All right, it's got to match the definition of tissue reactivity and if you felt resistance or not. So if you were pushing superficially and they report pain, you're pushing in a way in which you would not feel resistance back from that tissue, therefore it's high. Now, if you pushed either moderately deep or if you push deep, in both cases you will feel some level of resistance. Therefore, the answer for that would be moderate. And if you pushed all the way deep and you did not get pain response at all, that's normal, and normal is low, so it would be low. So again, for this case, for number 3, the answer is high based on those 3 grades. Number 4, interpret the result of a strong and painless MSTT for both glenohumeral external rotation and abduction. This is sort of a trick question. That is normal, and that is normal for the supraspinatus muscle functioning. Was the tissue reactivity, number 5, of an MLT of the pec major if the patient had no pain at tissue resistance? Well, no pain at resistance is low. That is also a normal result, so it is low. 6, 7, 8, 8 are all true and false. So is a tight muscle a tissue-specific impairment? No. So what I would be thinking to myself is, what is it missing? What do I have to add to this to make it tissue-specific impairment? And if it's a tight muscle, one is, I know what's wrong. I know the impairment, tight muscle. But what is the specific tissue? You know, is it the right biceps muscle? Is it the left pectoralis major? Is it bilateral pec minor tightness? That's how we could turn that tight muscle into tissue-specific impairment. Is it bursitis a tissue-specific impairment? That is also not. What is it missing? Which bursa are we talking about? There's many, many bursa in the body. So pick one. So maybe we could say this is a greater trochanteric bursitis. As we move on, weakness of the right triceps muscle is a tissue-specific impairment. All right, finishing up here, number 9. This patient is very much like the patient that sprained their ankle and had the ATFL complete tear, which we've already reviewed. But this patient doesn't have that tissue-specific impairment. Their tissue-specific impairment is only effusion of the right talocrural joint. Right talocrural joint effusion. Do not be thrown off by hypomobility. Hypomobility is a quantity. We're telling you it doesn't move enough. So if you look under accessory, it says it's hypomobile. It doesn't move enough. Well, so what? So what if it doesn't move enough? What is the cause of that impairment? Well, it's not moving enough because it's full of swelling, and it's the joint that's full of swelling because I'm on passive range of motion accessory. I know that it's the joint. So it's effusion or swelling within that joint, and I have to name the joint. So effusion of the right talocrural joint, or joint capsule, you could say. Stage condition in this case is acute. She's not getting any better. It was 2 days ago. There's still swelling there, the same amount of swelling. So based on those variables, this is acute. What is a tissue reactivity? That is moderate because under accessory, when we stress it using passive range of motion accessory, that would be the best step to stress the effusion of the joint. We do get that end field swelling, and there's also pain, so that means we have pain at the resistance. What is a subject reactivity? It is high because he cannot carry out his job duties as a walking mailman. And what's a good functional activity goal? Well, a good functional activity goal would be a patient able to partially weight bear on the right lower extremity to move envelopes from a table to the mailbox or simulated mailbox 10 times. This would be a great goal for you to work on in clinic. That's functional, objective, and measurable. It gets the patient back to their goal of working again, and it directly relates to their job duties, which, according to this very abbreviated case, is all you have that on. So please email me if you have any questions about this. It just hits a lot of review topics that we've gone over before, so just kind of cementing those home. So if you're not sure, go back and look at all the information we've covered. Read the clinical management sections of both your E1 manual and of your notes and all those references that are listed. Once you have done all that, you should have a very solid understanding of this. Go back and listen to the lectures in which I covered this material. You have all the resources there, so make sure you know this material, and if you still can't figure it out, then email me, and directions were gone over the first day of class and in your syllabus as far as the correct way to email your questions so that I can help you best. So I will see you guys in class tomorrow. Thank you. Bye-bye.